meeting. This meeting is being recorded. We have a great update today. Looking forward to hearing from the cardiovascular disease domain team. And before we actually go to that, a quick announcement and reminders. So next week is Thanksgiving, and there's no meeting next week. And then the week after, on the 29th, Monday 29th, we'll have Melissa Handel, Emily Paff, and Andrew Gerving talk about who has long COVID and their big data approach. And then this is the schedule for the upcoming meetings that we include those in the slide deck that people can refer to. The quick stats: 67 sites. The data keeps on increasing in the enclave. We have 9.2 million patient records, and out of those, approximately 3.2 million COVID positive patients. Total number of rows exceeded 10.3 billion rows. And now I'm going to turn it over to our cardiovascular disease team. I stop sharing. Scott, yourself or Brijesh will take it over.
Scott, can you share those things?
Yeah, I'm going to pull it up here right now. Is it there?
Not yet.
No, nope.
Okay.
There we go.
We see it.
Excellent.
You do you want to start the slideshow?
There we go.
Okay.
Perfect.
Well, I think I will start us off and kind of go from there. So just for those of you who don't know me, my name's George Sokos. I am a cardiologist, a heart failure cardiologist and transplant specialist at West Virginia University, and work closely with Dr. Patel and Dr. Chapman as domain team leads. And I just wanted to go through our process of our team and some of the projects that we've been working on, and just to kind of give a little background on our team. So if we can, next slide, Scott. So obviously every team has to develop a mission, and we wanted to better understand the effects of COVID-19 on patients with new and existing cardiovascular disease, including but not limited to acute MI, heart failure, stroke, coronary artery disease, and to determine the effect of COVID-19 on outcomes, including mortality, hospitalization, and access to care. So pretty broad scoping mission statement, but we wanted to be inclusive, obviously, of as cardiovascular disease is pretty broad in itself. We wanted to make sure that we included the necessary disease states to discuss and learn and research about. Next slide. So this is the three of us. Again, we've worked pretty closely together, and we have, I think, a great team concept. We meet weekly, sometimes more often, depending on if abstract deadlines were coming up, to work on things through the domain team. So I think we just have a great relationship with the three of us, and has really solidified our domain team and what we've been able to accomplish so far. Next slide. May not know, we have a pretty diverse team, and really from a lot of the country. So Scott's in Minnesota, has two others in his on his team there. We have folks from New Jersey at Rutgers, Maryland at Hopkins, obviously here at West Virginia, not only at West Virginia University, but through our Clinical Translational Science Institute. So we have folks at the West Virginia School of Osteopathic Medicine as well. And so really we're including ourselves as one institution, but we really include more than that. We have team members at Emory University in Georgia and at UAB in Birmingham, Alabama. Next slide. And not only do we have a diverse team involvement from location, we have multiple levels of the team, including students, clinicians. We have data analysts, stats, and admin. Again, I think probably most teams have that, but we've had some really good involvement, not just from medical students as well as PhD candidates in the analyst team. So I think it's been a learning process for all of us, and I think it's to have eager team members on all levels has really helped move our team forward and has helped, I think, with the entire process. So I think it's been really fun, and having all these different people involved. So next slide. This is kind of the timeline. I think we've gotten a nice amount of work done over the last 7 to 8 months. So we first met in February. We got a common DUR approved. A lot of meetings between February and April. Our first project by Dr. Patel, he's going to go into it a little bit more, talking about cardio-oncology. As part of that, we felt that it would be really smart on our part to understand the things that have already gone on in the oncology team, as they were already somewhat further ahead than us on projects. So we were able to meet with the oncology team to understand some of the data that they were able to obtain and understand some of the projects that they developed, and really helped us with our first project of the cardio-oncology project. So I think that was extremely helpful. It was a learning process for us. And then we were, at the same time with that, we formed our data team, learning from the oncology team on how they pulled their data and how they looked at things. And it really helped us to move forward. So over the summer, we were able to, put together a lot of the data and really try to make sure that our concept sets were accurate and were giving us the information that we wanted to get. And as we move forward with those projects, we tried to develop a template to allow others to create new projects for the team that would make the project fluid and include everybody that they need to include. So that we really have a nice template that Scott really spearheaded and worked with Jake Neumann to make that happen. And really led to us getting 5 abstracts submitted to the ACC, which we're very excited about, and is leading to several other projects that we hope to be able to submit and present at future meetings as well. So that's a quick overview of our timeline. And we're going to go into Brijesh's projects now, but any questions or input on how we went through that, or should we probably hold questions to the end so we can get through the presentation and let Brijesh move forward here?
Thank you, George and Scott. And I would like to thank the entire N3C collaborative committee to put a very robust data on COVID-19 and collecting data throughout the pandemic. So I'm going to start with the project that I analyzed recently, and working on finalizing data and writing manuscripts. So by training, I'm a cardiologist, but have a special interest in cardio-oncology, which is a very emerging field, but full of challenges. So next slide. So one of the ideas came to my mind was, I see a lot of patients with cancer and heart diseases, and this question came to my mind as I was reading through this in a lot of early literatures. And as we learned throughout the process that having comorbidities disproportionately affect patients with the comorbidities and especially if they have a cancer and heart diseases. So I hypothesized this question that what if patient with both conditions, cancer and cardiovascular conditions, if they have both conditions together, what would their outcome be? Now, recently from oncology domain, they published a paper and they did analyzed cancer patients, and our definition of cancer was slightly different. We included more active cancer patients, but nevertheless, they have shown that the patient who have cancer or recent cancer, they are more likely to suffer poor consequences after they're infected with the SARS-CoV-2, I would refer as COVID-19. So with that background information in the mind, I added cardiovascular conditions on top of it and see what we could come up with in terms of data. Next slide, please. So as we know, we have multiple millions of billions of rows of data, and so we started with N3C cohort, and then we had a very strict definition of who would be considered COVID positive. So we defined the patients who were COVID tested, positive or negative, with 21 days or 3 weeks before the hospitalization and 5 days after. So we chose this timeline because we think that the acute effect of COVID will still linger within 21 days after the initial testing. And as we know, in the beginning, we did not have any good turnover in terms of COVID testing because we were lacking equipments and hospital was not really ready. So to capture all the patients who were COVID positive while they were hospitalized, we extended the rate, the range of testing up to 5 days after hospitalization. We included, for the analysis purposes, we included both patients who had COVID positive and negative, because that's, and we'll talk about the data in detail, but we want to be very inclusive. And those who did not have testings were excluded from this cohort. So once the cohort was established, we divided into 4 groups: cardiovascular, which stands for CVD, negative, meaning COVID negative; CVD positive, meaning have cardiovascular conditions and they have a COVID positive status; cardio-oncology cohort, which means patient had active cancer. And we defined active cancer as if they were received, if they had a cancer diagnosis code, and we excluded patient who had a skin cancer other than melanoma and non-specific malignancies. So if they had active cancer, we define active cancer as if they have a cancer code, plus if they got chemotherapy within 30 days of hospitalization. So we really focused on the patient with active cancer rather than chronic or remission status. For leukemia and lymphomas, we also excluded patient who had in a remission state. So that way we don't capture the people were successfully cured. Likewise, we also looked at the patient who had their cardiovascular condition, active cancer, and COVID positive status. Now you can see we defined heart disease cohort as if they have chronic heart failure, ischemic heart disease, prior surgery, valvular heart diseases codes. Again, these are based on ICD-10, 9 and 10 codes. Peripheral vascular diseases, and if they had a device implantation or prior heart transplant. Now, one question comes to my mind: why did we choose cardiovascular implantable devices? Well, if you think about it, most of the devices, let's say defibrillator or pacemaker, are put in because of they have some sort of underlying cardiovascular condition, which could be serious, especially in the case of ICD. So we wanted to make sure that those patients are also adequately captured. Next slide. So the majority of the cohort, as you can see, consists of CVD negative. So the majority of the patient had COVID negative status. So all of the patient, our underlying cohort, they all have some degree of some type of cardiovascular diseases. But the majority of the patients were COVID negative, followed by cardio-oncology cohort, but they were COVID negative. So COVID negative had almost made up almost 88% of the cohort. Now, the cardio-oncology positive was very small, up to 3,000 patients or so. So it consisted very small fraction of the entire study cohort. Next slide, please. Briefly, in interest of time, because we have other studies to present, I just presented the main findings of our study. So if you think of like a cardiovascular COVID negative patient cohort as a reference, the adjusted odds ratio for having COVID positive was almost 2.5 to 3 times likely for primary outcome, which was mortality. And when we looked at the patient who had cardio-oncology negative COVID status, it was slightly less than the cardiovascular disease, but with the positive status. Now, when you have all three conditions, COVID, cardiovascular disease, and cancer, obviously the mortality risk is tremendously higher. So this goes to show that the impact of COVID positive status was much more profound than if you have almost two severe conditions, cardiovascular and cancer. So COVID positive status had much more impact on their poor outcomes than if they were negative. As you can see, we have some other analyses, so outcomes that reported. Now, one thing you might see, like, why is there a protective effect of cardio-oncology and in form of myocardial infarction, heart failure, and stroke? Well, think about it. So cardio-oncology patients are very heterogeneous group, because they may be admitted because they have anemia, they have a lot of electrolyte issue, chemotherapy-induced nausea, pneumonia. So they may not actually came in for heart issues. So we think that the primary driving force for these population was non-cardiac issues, whereas people with the COVID positive and cardiovascular disease, they obviously came in for COVID status, but they also had exacerbation of cardiovascular diseases. Therefore, we think that the mortality and everything was more driving the primary outcome. The role, the use of ECMO in COVID cardio-oncology population was much less. Maybe, we don't know for sure, but we think that because they have two terminally ill conditions, the utilization of ECMO or life-saving measures were less likely to be used. But again, we are not 100% sure if that's the reason behind it, because data does not allow the decision not to put patient on ECMO. Next slide, please. So in summary, overall, the MACE, major adverse cardiovascular events, was lower in cardio-onc negative, likely due to non-cardiac causes of admissions. The cardio-oncology cohort suffered higher odds of mortality when they were infected with the SARS-CoV. So again, I like to call it triple whammy. And because these patients are very susceptible to poor outcomes, we think that they should be taught about preventative strategies such as vaccination and mask and other measures that keeps them away from COVID positive, acquiring COVID. So I would like to thank and passing more baton to Aayush for, we have a couple more derived projects from this same cohort.
Yeah, thank you, Dr. Patel. So next, the title of our next study is COVID-19 outcome for cardiovascular and cardio-oncology patient after their vaccination. So we have seen patient infected with COVID-19 after vaccination, and we know CVD-onc are associated with poor outcome of our patient. Here in this study, the outcome and characteristic of patient with these two pre-existing conditions, CVD-onc after vaccination, is analyzed. So next slide, please. So this diagram shows how we define three groups: CVD-onc, cohort number 2, and then our third cohort, no CVD or CVD-onc patient. So we started from N3C cohort. We find COVID-19 diagnosis after first dose of Johnson & Johnson vaccine or second dose of other vaccine. We looked at hospitalized admission, ICU admission, ECMO, vent. We combine all together to create one variable if the patient required hospitalization or not. And we look at 30 days after COVID-19 diagnosis. We also look at MACE complication after the diagnosis. Then we build our data set. We divide our data set through these three different cohorts based on the pre-existing condition of the patient. If they have cardiovascular disease, I went to cohort number 1, CVD, if cardiovascular with cancer to second cohort, and rest of them to third cohort. Next slide, please. This plot shows the trend that we found over time. So the x-axis is V, a time difference between vaccination, COVID-19 vaccination, and COVID-19 diagnosis. And then y-axis that you see it, a number of unique patients that we have for each week. As you can see, we have quite high number for week 1, week 2. We have decreasing trend and until week 8. Starting from week 8, we see increasing trend. We see peak for between week 18 to 20. And after week 20, we see again a decreasing trend all the way to week 36 or 9 months after vaccination. Next slide, please. Here, this pie chart shows the demographic of our cohort and patients in our data set. If we consider all the patients in the data set, that vaccinated patient who infected with COVID-19, we have column 1. So as you can see, 58.3% of our entire data set are female, 13% Hispanic, 8% Black. We have quite similar percentage for our first cohort CVD and second cohort CVD oncology, CVD onc in column 2 and column 3. Next slide, please. So this table shows the odds ratio of hospitalization for different group of demographic group. We actually find adjusted odds ratio. Here we adjusted based on age, gender, ethnicity, race, and CCI index. We have 3 columns. Column 1 is our first cohort, CVD onc. Column 2 is CVD, our second cohort. And column 3 include all the patients in our data set. Starting from bottom of the table, we have CCI index score adjusted odds ratio for all 3 columns are significant and greater than 1, showing that the higher CCI index value is associated with higher chance of requiring hospitalization. And this is true and significant for all these columns, all of our cohort. If we consider all the patients or CVD onc, that's true. Going off for Black groups, so we have same result. So we have adjusted odds ratio greater than 1, all of them significant, showing that Black patients were more likely to require hospitalization compared to White patients. This is again true for CVD onc and CVD cohort. We also find out that younger patients who were younger than 70 had lower risk of requiring hospitalization compared to those who are older or greater than 70. Next slide, please. Well, I have one note here, sorry. I have one note here to mention. So reference group for each of these columns are different. So if you wanted to compare these 3 different cohorts to each other, we have it in the next table. Next slide, please. So in this table, we can actually compare 3 column or 3 cohort that we have, CVD onc, CVD, and then cohort number 3, that all the patients except for CVD onc and CVD. So we have adjusted odds ratio in first column, we have crude odds ratio in the second column. In our reference group is column 3, all the patients except for CVD onc and CVD patient. As you can see, starting from bottom of the table again. So CVD-onc patient and CVD patient were more than, we can say almost 3 times more likely to require hospitalization compared to our reference group, which is all the patients without CVD or CVD-onc pre-existing condition. Even when we adjusted the odds ratio with age, gender, race, ethnicity, and CCI in first column, you see that we have high greater than 1 adjusted odds ratio for CVD patient compared to, again, patient without CVD or CVD-onc pre-existing condition. Next slide, please. This slide shows the odds ratio of complication after vaccine. In the first column, we have MACE, which is myocarditis, a stroke, heart failure, and mortality within 30 days. In the first column, again, we have our first cohort number 1, CVD-onc. Second column is CVD, and third is our third cohort, everything without all the patients without CVD or CVD-onc pre-existing condition. We have fourth column here, which we consider as a reference group to compare, and those are unvaccinated patients, but having CVD or CVD-onc pre-existing condition. Consider this column equal to 1 because this is our reference level. Back to MACE in the first column, you see the odds ratio is less than 1 for CVD-onc and CVD. So both of them are significant. It's showing that we have lower risk of required MACE for CVD-onc or CVD patient who were vaccinated compared to unvaccinated patient. We have same result for stroke. We have same result for heart failure. So we have lower risk of any of these complications for vaccinated CVD-onc or CVD-onc compared to unvaccinated patient. Well, if we compare our result with column 3, which is vaccinated but don't have CVD or CVD-COM, we still have higher risk, and all of them are significant. Next slide, please. So as a conclusion, vaccinated patient with higher CCI as well as patient of color both had higher chance of requiring hospitalization after vaccination, after infection. And we also conclude that vaccinated CVD or CVD-onc patient had higher chance of requiring hospitalization compared to those without CVD or CVD-onc pre-existing condition. We also noticed vaccinated CVD or CVD-onc patient had lower chance of complication like MACE, stroke, heart failure after infection compared to unvaccinated CVD and CVD-onc patient. I'll let Aayush present the next slide. Thank you.
Hello. So 2 other projects that we are currently exploring is 1, hematological abnormalities in cardiovascular and cardio-oncology patients are associated with worse COVID-19 outcomes. And then number 2 was is time since last chemotherapy and COVID-19 outcomes in cardio in patients. So the inspiration behind number 1 is that there's a lot of people who experience hematological abnormalities. A lot of patients who come in with COVID have hematological abnormalities. So we want to see whether these patients are experiencing worse outcomes in this high-risk cohort. And the inspiration behind number 2 is that there is some concern that people who have recent chemotherapy might be more immunocompromised because of the effects of chemotherapy and then have worse COVID-19 outcomes if they're infected with COVID. So we wanted to see if that was true in this cohort. Both of these, I would say, are still in the exploratory phase. So that's why there's no conclusions. But what we we use very similar methods where we use logistic regression, and we calculated odds ratios for in-hospital mortality and mechanical ventilatory support in different hematological abnormalities for abstract for one. And what we found was that both CVD only and cardio-onc patients with either anemia or thrombocytopenia had more than 2 times the odds of 30-day mortality compared to CVD only patients with normal parameters. And then for number 2, we did not find any significant increase or any significant change in odds of CVD events, mechanical ventilatory support, or 30-day in-hospital mortality or 30-day mortality with recent chemotherapy. And recent chemotherapy we defined as less than 14 days prior to admission, index admission. In terms of next steps for both of these projects, we submitted these abstracts to the ACC conference, but we plan on adjusting for more confounders that are clinically relevant because there's many different causes for hematological abnormalities. So we need to be able to adjust for that. We also plan to expand the range of our chemotherapy because right now we're looking at people with active cancer with chemotherapy within 30 days. So we want to expand that to more than 30 days and look at the effects between recent and not recent chemotherapy. And then in terms of methodological limitations, I think challenges across all of these projects and something that we've been working on over the past couple of months has been how can we best identify acute events? Because if we're just using claims or codes or diagnostic codes that may or may not be might not be accurate or have a good predictive value. So we hope to do a subgroup analysis using laboratory information among patients with laboratory information to see whether the results persist. So for example, if our outcome is MI, we would want to look at troponin levels and see if they also have elevated troponins. And then one issue that we've been having is that there's a lot of missingness for laboratory values in the time of labs. So that can get a little bit confusing on how exactly which labs to choose and how to go about the study that way.
All right, so this kind of leads us into where we're heading to in the future now. So this is really, we started off with the cardio-oncology program, and doctors Sokos, Patel, and Chapman have done a really great job of trying to keep in mind throughout this entire process of how can we apply this to our future studies. We're not going to be just studying cardio-oncology, of course, the entire time, and they've really helped focus the group in terms of making sure we're staying on track to applying this to whatever's coming up in the future. And I just happened to be the next one in line to have a project to propose to the group. And basically what we're going to be doing is applying everything we're learning throughout this entire time frame to all of our future studies, and basically developing our new cohorts, adapting our current concept steps, modifying them as we need. And my project really is proposing how to really look into how pre-existing heart failure can alter the clinical outcome during a COVID-19 infection, and then how that infection can alter the progression of heart failure following. And this kind of a flow chart to really kind of look at the 2 different cohorts. And we're using the American Heart Association definition of what would be somebody who's at risk in our cohort 1. For heart failure versus somebody who already has a pre-diagnosed. My background is in pharmacology, so I've of course want to use medications as much as I can in terms of trying to look at see what's going on with our patients, looking at the positive and negative COVID groups, and then trying to determine what's happening clinically, either acutely in the hospital admissions, requiring advanced therapeutics or increased number of cardiac events, and then long-term, are they progressing into heart failure quicker with a COVID-19 infection versus somebody who is negative? Or is their heart failure potentially progressing worse to, I guess, more symptomatic potentially too, in terms of requiring additional interventions? So this is really where we're kind of the next step, one of the next projects that we're going to be focusing on in the future.
And just to add to that, in addition to Jake's project that he's presented as our sort of next step or future projects, a number of other projects have been presented to our group for consideration, and we're at various stages of gathering the information we need and using our approach that we're developing to be a more systematic approach to propose projects, evaluate them, and try to find the best team, if you will, or sub-team within our domain team to help support the different projects so that we can support as many projects as the team can support during our work within the domain team. And so what you see here is titles of 4 other projects that have been proposed to the group and are under early to mid-level discussions, if you will, in terms of pulling a plan together and pulling the data together for these projects. And I'll just comment about some team discovery and contributions that we are sort of thinking about and adding to the N3C community as a whole. Dr. Sokos mentioned earlier the project proposal template, which came together as we, as a team, started working through our first cardio-oncology project and started thinking about how we're gathering all our information, our aims and our purpose of the project and the objectives, and sort of our strategies and data elements, that sort of thing. And so the creation of the template was created out of that thought. Number of concept sets have been created around various cardiovascular disease projects, the cardio-oncology. There's a lot of effort around the concept sets for the disease states, the labs, medications that have been used in the other projects as well. And then, this is an idea of an initiation of an N3C domain team leads forum. And I know, Dr. Sokos, this is something that we met with the clinical scenarios group about last week. So talk about, can we put together a forum where all the domain team leads meet and talk about successes, challenges, learn from each other to help us all work better in terms of our efforts to use the enclave and the data and the N3C community to make ourselves more efficient and effective in the outcomes that we're hoping to assess and inform us about regarding patients and the care of patients with COVID. So with that, it's just a conclusion of special thanks to the N3C community for all their contributions and efforts. This work that's been done and the efforts with all the domain teams and with the N3C community has really been a value that we've all had an opportunity to benefit from, and we appreciate that. And George, Brijesh, any other comments on this slide here?
No, I agree. I think it's been an extremely good learning experience. And it's been fun to work with a lot of different people. And I think that's just an additive benefit to trying to get some good science out of the data that we have. So I don't know if Brijesh have anything to add to that, but.
No, absolutely. I mean, we're also thankful to WVU CTSI for providing statistical support and all the data analytics support. So that really helped us to propel through these 5 projects within short span of time and submit to ACC.
And I see some questions in the chat as far as how are we defining unvaccinated patients. And correct, the absence of vaccine isn't necessarily of an EHR isn't guaranteed that someone isn't vaccinated, as far as like, but that's we're using the best data that we have in the set. So.
I think a couple of folks have raised their hands. I'm not sure, how do we address, like, do we unmute them?
Yeah, I was seeing, I was monitoring the chat. There were some questions. I know some of you guys have been answering those questions. Yuri, do you know when you raise a hand, how do we give them?
Yeah, we can have them ask their questions directly. It's up to the panelists. Here, all right, Valerie, you should be good to go. And I also realize that sometimes folks hit the raise hand button on accident. So if you don't have a question, don't worry about it. Okay, it looks like Valerie, you don't have a question for us right now. If you do, go ahead and pop it into the chat. And there was one other person, but it looks like they've lowered their hand. So I think we can continue to go through the questions in the chat if you'd prefer.
Yes, I think there's a question. Andrew Gervin had asked a question, and I know I saw that Maryam was answering that. So I don't know if Andrew or Maryam, if that question has been answered. It seems like the questions mostly that were posted in the chat, they have been answered by the team. Dr. Patel or Maryam, do you guys see any question that's not answered? Because what I'm seeing is that I think all the questions you guys just went through and answered them in the chat.
Yeah, I'm just making sure. I think I will try to answer. But one of the question was, are we going to look into different effects of vaccine? So this particular project has not looked at it, but it was our discussion to look into different kinds of vaccine and how they impacted the outcomes. Hopefully it should be similar, but it will be very interesting to know.
Also, I see another question is asking, so vaccine does not offer protective effect in Black population. So I'm not saying that. So what we see is we see reports. I mean, we see higher risk for Black population compared to white population. So it's just they have higher chance of diagnosis with COVID after vaccination compared to white. It's not saying that vaccine doesn't offer protective effects in Black. It's just comparing the outcome, what happened after vaccination. Dr. Patel, do you want to add something to that to explain more?
No, I mean, that's what I was thinking. I think you answered it correctly.
We do have one more question in the Q&A that doesn't look like it's been addressed from Harold Lehman. Were there any sites or CDM effects? Any suggestions for handling missingness not at random?
I can answer that briefly. So we actually have not really looked at side effects. I think that's definitely something that we want to look at, how different hospitals might be coding diseases differently. The other thing about handling missingness not at random. So we've actually just been doing a complete case analysis, meaning we've just been looking at people with complete data and not really addressing the missingness. But I'm actually, maybe Maryam or someone else can answer that about the missingness not at random, how to exactly handle that.
I can't find the question. Can you repeat that for me?
Yeah,
oh, yeah, sure.
absolutely. Also, just really quick, it's in the Q&A section, which is separate from the chat. So it'll appear at the bottom when you mouse over the bottom buttons. So there are two places where questions are
I
coming
see.
in. Yeah. So the question was, were there any site or CDM effects? Any suggestions for handling missingness not at random?
Oh, so we do have a site. We know that we are not getting complete. We might not get complete data from a specific partner or specific site. But for example, when I was studying a vaccine, what I tried to include to my analysis for sure those information that I have and I receive, and I'm not taking care of which site provided that because it just doesn't matter. And the other thing is when you find CVD or CVD-onc or pre-existing condition for patient, it kind of guaranteed for us that we have a good amount of information for that patient. You have the vaccine information, you have their pre-existing condition, you have their cancer, you have their cardiovascular condition that they have previously. You see the complication after that. So it kind of, to me, it's a kind of guarantee that we are removing those patients that kind of we are missing or, and the other thing that we can always think is try to, when you make conclusion, try to keep this in your mind and then always go in a way that you see the data, just conclude based on what you have. Or I don't know if I'm answering this perfectly or not, but that was my suggestion.
One of the comment made by Andrew Girwin mentioned that, when they looked at some of their data, they found that the missingness was associated with a poorer outcome. Now, I'm not sure was it specific for any lab values or not. I mean, at least I can say for cardio-oncology project, when we had missing value for covariates, let's say diabetes, hypertension, we assumed that the patient did not have diabetes. We did not look into whether they had hemoglobin A1C or glucose level at certain values. So we strictly went by the ICD-10 codes to capture the diagnosis. We did not include any lab values or any blood pressure or BP, like continuous variables. So, but it is very interesting to know that missing values could lead to poorer outcomes, and I'm open to learn more about it. How can we should we do imputation, or should we do some other method or some statistical way of incorporating the missing values?
And I think we want to be careful not to assign a disease state based on one lab value or one finding, because we know that multiple, particularly let's say with respect to diabetes in particular, a lot of our COVID patients were treated with steroids, and you can get hyperglycemia from that. And to assume that someone has diabetes based on elevated glucose levels wouldn't be prudent on our part. Those sorts of things. We talked about that, but I agree with Brijesh. If there's things that we could learn by looking at, I think we'd have to be pretty pointed on what we would want to look at with respect to missing variables to answer that question. I think. But I'm not a statistician, so that's why it's one of the reasons we like to present here as well, is to get ideas.
Yep. And Dr. Girwin answered back and says they were missing for lab values, and makes sense to me. I was working with N3C, not N3C, sorry, Trinetics that feed the data into N3C before N3C was formed. And my personal experience with the lab value was that many people, patients, I should say, were missing lab values. And so it's really challenging, in my opinion, to do lab-based analysis. And, at that point, we can't do it. We can't do anything about it, unfortunately, because we wouldn't know. And a lot of people are missing lots of values, including vital signs. That's, obviously, let's say you can make a case for lab values. Maybe it was patient died before they were drawn or something, but I can't believe the heart rate and blood pressure parameters were not captured. So yeah, it is one of the limitations.
Awesome. I think we answered all the questions. I want to thank you, Dr. Chapman, Dr. Patel, and Dr. Sokos. Thank you so much for a great talk and discussion.
I have a slide here advertising our cardiovascular domain team. If you're interested in more of what we're doing, come and pay us a visit. Our next meeting's tomorrow at 5 p.m. Eastern, 4 Central. Thank you all very much.
Thanks everyone for joining.
Thanks, everybody.